So good morning, everybody. My name is Barbara Casolla from the Vascular Neurology Department of Nice in France. And I have the honor today of being with Professor Karin Klijn, who is the chair of the Neurology Department at Radboud University Medical Center in Nijmegen, the Netherlands. She is the co-principal investigator of the randomized clinical trial Apache Af, which is the acronym for Apixaban after anticoagulation-associated intracerebral hemorrhage in patients with atrial fibrillation. And she co-led this randomized clinical trial with Professor Bart van der Horst from Utrecht Medical Center. Good morning, Professor Klijn. It's a great pleasure to be with you. So, Professor Klijn, could you please tell us more about the rationale of Apache Af trial, please?
Yes, thank you very much, Barbara. Patients with atrial fibrillation who are on anticoagulation may experience an intracerebral hemorrhage while they are on this medication. And we have a long-standing and pressing clinical dilemma whether after the ICH should we restart the anticoagulation or avoid anticoagulation as the best long-term strategy for the prevention of recurrent stroke, either intracerebral hemorrhage or ischemic stroke, and systemic thromboembolism.
And can you briefly summarize the design and the patient selection of this study?
Yeah, we performed a phase 2 randomized controlled trial to really, for the first time, have reliable estimates from a randomized comparison of patients who did and who did not restart anticoagulation, and we chose as our treatment arm Apixaban. And we performed this in 16 centers in the Netherlands as a phase 2 open label clinical trial with blinded outcome assessment. And our main inclusion criteria were that the ICH had to have occurred while patients were on anticoagulation. And the timing of that was in the previous 7 to 90 days. Patients had to have a CHETS-VAS score of 2 or larger and a modified Rankin score of 4 or smaller. And then we randomized them 1-to-1 to Apixaban 5 milligram twice daily or avoiding anticoagulation. And in the anticoagulation group, the physicians could choose whether or not they wanted to start an antiplatelet, for example, if there was another indication for antiplatelet therapy. Our primary outcome on purpose was the combination of non-fatal stroke, so including both ICH and ischemic stroke or vascular death.
Thank you. And which were the main difficulties you faced in the recruitment of patients in Apache Af?
Well, we had a slow but steady recruitment rate, and our main issue was actually we also looked at that many patients who have an ICH while they are on anticoagulation, they do not survive. So that was the main reason why people could not be included. And we had some instances as well of doctors or patients having a strong opinion about the treatment, despite the fact that there's no evidence on what is actually best for secondary prevention in this patient group.
And what were the expected results for Apache Af, Professor Klijn?
Well, expected is always difficult. Of course, we had a hypothesis. In the earlier days, some years ago, people were very reluctant to restart anticoagulation. And I think we were more afraid probably of ICH than of recurrent ischemic stroke, which resulted in the fact that only a very small percentage of patients were restarted on anticoagulation. If you look in the literature, around 20%. In later years, observational evidence, which is of course confounded, showed that it might be safe and maybe even better to restart anticoagulation. But there was no real numbers, especially not from the time that we now give NOACs instead of vitamin K antagonist. So our purpose really was to get reliable estimates from a randomized comparison, but with the idea that restarting anticoagulation might be in the end be beneficial. But of course, in this phase 2 study of 100 patients, we could not have a definite answer to that question.
And what did you finally find? So,
well, we randomized 101 participants with a median age of 78 years. 28 had low bar ICH. And we followed them for almost 2 years, 1.9 years in total, in the median. And 222 person years of follow-up. Of the 50 participants who were assigned to Apixaban, 13 had a primary outcome. And of those assigned to avoid anticoagulation, 12 of 51 participants had a primary outcome. And that resulted in an annual event rate of 12.6% for the Apixaban group and of 11.9% in the group that avoided anticoagulation, indicating that the annual event rates were similar with overlapping confidence intervals, and that the event rate was high in both groups, irrespective of which treatment they received.
Thank you. And do you think that there are any other potentially identifiable risk factors or underlying conditions that may be considered for the risk-benefit balance at the individual level?
Yeah, of course, that's a very important question. This is if you look on the group level, and we did exploratory subgroup analysis in this study, but those are, of course, not, they can only be hypothesis generating, and they cannot give a firm answer due to the small numbers. But a very important question always is in patients with low bar ICH due to cerebral amyloid angiopathy, where we know that the risk of ICH is higher than in those with non-low bar ICH. Should we not refrain from giving a NOAC in this group? As for now, I think it is an important question, but based on the current evidence that we have, I think we still need to continue to randomize those patients in those trials that are still ongoing. And there's actually 5 other studies still ongoing addressing this question in a not exactly the same but similar design. Because at the moment, we also for this group don't know what the best secondary preventive treatment is.
Thank you very much. And going forward, do you think that these criteria could be used to stratify the inclusions of patients in the next trial on anticoagulation in patients with history of intracerebral hemorrhage and atrial fibrillation?
I think for now we should not restrict inclusion to specific groups of patients. I think we really still don't know, and only by including all patients with ICH while they are on anticoagulation in the ongoing studies, we will be able to reach the numbers that will be needed to look at specific subgroups of patients with specific characteristics to really come to an individualized risk assessment. And the numbers of the trials and probably the combination in the end of the results in an individual patient data meta-analysis should allow for this reliable subgroup analysis, so we can in the end know the answers and have more individualized treatment, but not at the moment yet.
Thank you very much. So with the results of the ongoing clinical trial, do you think that we will be ready for a clinical radiological score to guide clinical decisions in treating these patients with anticoagulants and with both history of ICH and atrial fibrillation?
Yeah, I think it's very important that the ongoing trials continue and that we obtain more evidence. And hopefully when all these trials are finished and all the results are combined, we will be able to do exactly that and have more personalized guidance for the best secondary preventive treatment in these types of patients.
Thank you very much, Professor Klijn, and really congratulations from all the vascular community to you and to your team for this big achievement. And we thank also the organizers for the great opportunity to highlight the importance of this research topic, which we deal in our routine clinical practice. So we can't wait for the results at the randomized clinical trial session of the Esoc 2021. Thank you very much.
Thank you very much.